I'm going to be talking about the impact of AMR, that's antibody-mediated rejection, and the impact that's happened in Adelaide in a single centre about measuring these angiotensin receptor or ATR antibodies prior to transplantation and changing the way that we manipulate them at the time of transplantation. So Adelaide has a population, or the South Australia and the Northern Territory, as you see there, span Darwin right in the top, right down to Adelaide in the bottom, and that's about 2,600 kilometres, so that's a pretty big distance that we have to cover. And the population is, overall it's around 2 million, but about 1.1 million is in Adelaide, and then there's a smaller population in the centre, in Alice Springs, and then in Darwin. So when we have to get people down for their transplants, there's almost an obligatory sort of 18-hour ischemic time for some of these people to come all that way. And the other issue is that the people in Central Australia and the Northern Territories are Indigenous, so about 25% of our transplant turnover is Indigenous Australians. So, and with that occurs a whole series of issues with socio-economic problems, drug adherence, and exposure to infections. And I was just saying to Eloise that we had a period of time where we stopped transplanting Indigenous Australians because the death rate was so high from infection, and we've sort of tried to rationalise that a little bit, but it's a real issue for us. It's actually not just rejection, but infection and death from infection. So that gives you an idea of the size of the population and the geography that we are involved in. Sorry, next slide. So Adelaide did the first successful live donor transplant in Australia in 1965. We do about 90 transplants a year, and we have about 900 prevalent transplant recipients with a functioning graft. And yesterday I presented in Winnipeg, and when I put these waiting times of 12 to 18 months for Blood Group A and 24 months for Blood Group A, there was a bit of a shock how short the waiting times. So we've, at any one time, we've got about 50 to 70 people on the waiting list, and it's important that I talk to you a little bit about how things have changed, because it does sort of put Adelaide in context. So in 2009, when I arrived from the UK, we had about 15 or maybe 20 people who'd waited more than 5 years, and they were basically staying on the wait list because they had a donor-specific antibody, but their T and B cell cross-match was negative. And within that first year, there were 3 people who essentially died on the wait list because they essentially weren't being given an option of having a transplant. And so we changed our policy that we would accept any donor-specific antibody up to a 4,000 MFI if the CDC was negative. And we didn't do anything differently. We did not plasma exchange them. We didn't give them ATG. They all had an IL-2 blocker. And the other thing that we did was that if they had waited more than 5 years and they had any DSA and the T cell and B cell cross-match was negative, they were given the graft, because all grafts, 80% of grafts are given out in waiting time, and about 20% of grafts are given out on matching. And so maybe 2 or 3 people a year over the last 6 or 7 years have been given perioperative plasma exchange and ATG for donor-specific antibodies, but they have to have had a T and B cell cross-match negative.
CDC negative, you also do a B cell and T cell cross-match?
No, no. So they only for live donors where we had time, we have a flow cross-match. So time is one thing, expertise is another. We're only just doing our own flow cross-matches in Adelaide. All the live donors would get their cells and sera sent to Victoria and Melbourne, and we centralise it there. But we are starting to do our own flow cross-matching. So it does sort of put this into perspective that this would be something considered high risk in Canada. As far as I can see, you don't even get a look in if you've got a donor-specific antibody. And we were like that in 2009, but we felt that we weren't being equitable to people, so we changed our policy. Now, sorry, next slide. So that's just to put in context what we're doing in Adelaide. But really, because I'm talking about angiotensin receptor antibodies, and that's all about blood vessels, I do want to sort of just go over this concept of microvascular damage, because BAMF has changed in 2013. So next section or next line. So what we'll talk about is the fact that we had interactions with Dr. Dragun in Berlin, and in 2012, 2013, she told us of a protocol she was using and the fact that they hadn't seen any AMR in their population in the last 12 to 18 months, and we thought this was staggering. And so next section, we looked at what had happened to our patients that had had bad antibody-mediated rejection. And I have to say that the subsequent slides will be antibody-mediated rejection in the complete absence of HLA DSA. So these are not people who have been transplanted with a DSA. These are people who we looked before transplant, at the time of rejection, and afterwards, and we couldn't find an HLA DSA, and yet we had horrible antibody-mediated rejection that required an awful lot of treatment, and I'll show that in the subsequent slides. So what I'm going to talk about is the differences between the Adelaide and Berlin protocols, because we did a bit of analysis looking at thresholds of risk. So next slide. So, and just next, there'll be a few boxes. If you just press the slide again, they'll light up. So it's this whole idea that BAMF 13 really has really focused on the vascular endothelium, and although we can talk about glomerulitis and PTCitis, that really it's all about vascular damage. And in the bottom there it says you can have antibody-mediated rejection, and it doesn't have to be an HLA antibody, it just has to be an antibody that's known to cause damage. And so this is where I'm talking about is angiotensin receptor antibodies. So just to have this idea that it's all about vascular damage. So next slide, please. So this is from the French group, and what this is really showing is that what they said was that they followed thousands of people long term, and the group that did really badly were the people who had evidence of antibody-mediated rejection and a vascular lesion. And in the sort of editorial and in the paper, what they really said was, is it that we're misdiagnosing antibody-mediated vascular rejection, or is it that we're mistreating it or treating it incorrectly? And there's probably an element of that in the paper, that these people were thought to have T-cell mediated rejection, where actually they probably got an antibody and weren't treated appropriately, and that's why the graft outcomes were pretty bad. So next slide. And what they did is they looked at all of the histopathology scores in all of the different compartments, and they said that there were really 4 types of rejection. There was cellular rejection, which is your classic tubulitis and interstitial inflammation, that when it gets severe, it spills over into the vascular compartment, and that's sort of the classic BAMF, sort of 2A, 2B. And then there was the antibody-mediated rejection elements that when they got bad, they spilled over into the vascular compartment too, but they didn't have the sort of classic tubulitis and interstitial infiltrate. Next slide, please. Now, I can see. So the take-home messages of these slides really, and it's quite hard to see on this slide, but the antibody-mediated rejection without the vascular component was more likely to be C4D positive, whereas those with the vascular component were C4D negative, and that's unusual. And the other issue is that people with a vascular AMR without the vascular component here tended to have a DSAs, whereas those with the vascular compartment AMR tended not to have as higher amount of donor-specific antibodies. And all of the information is in this microvascular compartment, so in the G scores and the PTC scores, whereas if you've got classic cell-mediated rejection, it's your classic sort of interstitial inflammation and tubulitis. So, and just next slide. So what was interesting though is that of those people who had AMR, they could only detect antibodies to HLA in about 40 to 60% of the time. So my comment is what's happening in the other 40%, and given the fact that this is all occurring in the vascular tree, I think it leads on to talking about antibodies that bind to the vascular tree. So next slide, please. So This is a slide given to me by Dushka, who sort of first described angiotensin receptor antibodies in 2005 in the New England Journal, so it's taken us nearly 2 decades to, or thereabouts, to accept that they might be clinically relevant. But we've all heard about antiviral antibodies in heart transplantation, and tubulin antibodies in lung transplantation, and MICA as well in cardiac transplantation. But I want to talk about the ATR antibody receptor, or the angiotensin receptor 1 receptor, and it's on the endothelium, and it's a transmembrane protein. So it's ripe for being attacked by antibodies and to cause a vascular lesion. So next slide, please. So the issue with angiotensin receptor is that there are lots of things that we do in transplantation that cause its upregulation, so ischemia, reperfusion, brain death itself, and the cytokine storm, and CNIs are known to upregulate these on the surface. And you can see that there is a natural agonist, the angiotensin, but there's also an element intracellularly where we can add in sartans such as candesartan or irbesartan. I don't know what the classic ones here are in Canada, but this can be bind to the receptor. And the other issue is that there are known polymorphisms in these receptors. So you can have little or no injury or intermediate phenotype. So there is a polymorphic drive to the outcomes of these receptors. But just to say that the process of transplantation can cause upregulation, and you can see that there's an angiotensin receptor antibody that binds to the second transmembrane section of the receptor. And it's important to understand that G protein coupled receptors, or these transmembrane receptors, are all about conformation. They work by changing conformation. So next slide, please. So on the left, if you manage to bind a sartan or candesartan or irbesartan in the absence of an antibody, you can lock it in a conformation that means that the antibody cannot bind. So you can lock out the antibody. So the antibody can be at very high concentrations, but as long as the sartan is there first, the antibody can't bind and can't mediate the effect. And so you have this issue that if it's in its active conformation, the antibody can bind and can keep the receptor on permanently almost. But if you manage to get the drugs in first, it doesn't matter whether the antibody is there or not, it can't bind. And that's the premise of what we're going to be talking about. So next slide. So we all accept Graves' disease. We've accepted Graves' disease. We have that in Graves' disease, the thyroiditis. So essentially, we've accepted since 1895 that there are antibodies directed to the G protein coupled receptor on the thyroid that causes a localized thyroiditis, and that is a agonistic, long-acting, activating antibody that we've accepted exists in Graves' disease for centuries. Well, exactly the same antibody that attacks the ATR receptor just happens to be on all tissues and all cells. And so it can cause a vasculopathy, it can cause fibrosis, but it can also cause activation of immune cells. So it has a panoply of problems or activation issues. Next slide. And the reason I put this in is I sort of work in pediatrics and in transition of sort of young adults from the pediatric service to the adult service, and there have been a lot of issues with what we thought were technical failures in pediatric transplantation, but it turns out that a lot of the times, and it's biased, is that these children have had very high levels of these agonistic antibodies, and they're known to cause thrombosis. So they cause not only all those other things I've talked about, but they cause a coagulopathy and coagulation. So I think that's an important point, because we now screen all of our pediatric recipients, particularly because of the risk of primary graft failure. And I'll talk a little bit later about the Johns Hopkins protocol, where if they've had technical failures, in inverted commas, they screen for these antibodies because there's an association with graft thrombosis. Next slide, please. So these were the first studies looking at the risk of humoral or antibody-mediated rejection in groups that were pretty much extensively assessed not to have HLA antibodies. So they screened out a whole series of people and made sure there were no HLA antibodies, and yet when they assessed these people, they found that having angiotensin receptor antibodies increased their risk of getting antibody-mediated rejection in the absence of HLA antibodies. And on the right is the NONT study, where there seems to be a threshold level for 10, and on the left it was an American study where the threshold seemed to be 17.5, and this is the premise of risk stratifying people for humoral rejection in the absence of HLA antibodies. Next slide, please. And Teresaki, who was the sort of grandfather of HLA antibody testing, what he showed was that if you had an abnormal biopsy, and that didn't have to be rejection, it could be ATN, it could be just minimal interstitial infiltrate. If you had an abnormal biopsy at any point that didn't have any antibodies, your graft survival was still pretty poor at 6 years. That's sort of a 60% 5-year survival. But if you had an HLA or an ATI, you did pretty badly. But if you had an abnormal biopsy, which didn't necessarily have to be rejection, just abnormal, but essentially all of those grafts were in the bin in 3 years. So there aren't many people in that whole cohort of 130. But if you had biopsy abnormalities and you were biopsied for a reason, and you had both of these antibodies, the outcome is pretty ordinary. Sorry, next slide. So based on this and based on those studies that I've shown you, the Berlin group essentially risk stratify people at the time of transplantation such that those people with levels of 17 or above get preemptive plasma exchange, they get thymoglobulin rather than an IL-2 blocker, and they get candesartan at the time of transplantation. So they're given candesartan at the time of transplantation, pre-op and post-op. And if they've got levels above 10, they get exactly the same, but they just don't get plasma exchanged. So already when I showed this to the group in Adelaide, there were major issues about giving A2 blockers at the time of transplantation. And this caused a major sticking point for us even thinking about using candesartan perioperatively. Next slide. So what's really interesting though is that if you actually look at the data, the converse, there aren't many papers, but it's actually the converse of what you'd expect. So this German group in 1983, and when my registrars see that I'm actually quoting things in 1983, they think I'm mad. They can't understand why the data's not newer than this. But in 1983, this group essentially gave, next slide, they gave angiotensin receptor blocker, an antagonist, a small molecule, and they just randomly gave it to 24 kidneys before implantation, and what they found was that if they gave the blocker, they were less likely to have oliguria, and they were more likely to have spontaneous graft function. So that's the first piece of evidence that it looks like giving these in controlled situations. And what I'm saying here is that this is not somebody who's had a non-steroidal, they become hypotensive, they become volume deplete, they may have had another nephrotoxic or sepsis. This is giving people an A2 blocker in a controlled volume replete situation. So it's a bit different to what we see in acute kidney injury. I think that's important. So next slide, please. The second bit of evidence was there's another group in 2004 that essentially said to the people who came to them on an ACE or an A2 blocker, do you want to keep on with your medication or do you want to stop? So it wasn't randomized, but these people were kept, either did or did not keep on with their pre-transplantation ACE or A2 blockade, and there was no effect on immediate graft function. There was no effect on DGF. And in fact, if you had delayed graft function, your recovery to renal function was actually quicker if you're on an ACE or an A2 blocker. So again, there's evidence that it may be safe, but again, it's this issue of in a controlled situation. And there's now increasing evidence that if you continue your ACE when you're coronary revascularized, you actually have less kidney injury as well. So this started to let the other physicians think about letting us use candesartan at the time of transplantation. Next slide, please. This is just a graph of the return to recovery if they were on an ARB or not. So next slide. So there were a few things that happened in 2013, 2014. We had a horrendous year for AMR with no HLA antibodies. I think it was just chance, and we only do 90 transplants a year. We do a lot of retransplantation, so about 30% of our grafts are retransplant. And we also had this issue where the prevalence of these antibodies is probably higher in the pediatric population, and we had an ongoing and increasing relationship with the pediatric hospital, and we were probably seeing a lot more of these antibody-mediated issues in the pediatric population. So, and the fourth thing was that Toby Coates, who's the director of transplantation in Adelaide, had an ongoing association with cellular assays. So it was a combination of these things that meant us really think about whether we should be testing for these antibodies. Next slide. So in order to sort of develop evidence to suggest that having these antibodies was a problem, we went back retrospectively in 2013, 2014, and we looked at those people who got antibody-mediated rejection in what was essentially the absence of HLA antibodies. And I excluded 18 because we were involved in the eculizumab studies. I'm not sure whether you were involved in those, but this is a complement inhibitor. So we were involved in those studies, and so those people were excluded because they were desensitized with plasma exchange for HLA antibodies. Next slide. And it was a horrendous year, so just press the button again and it'll bring up some boxes. Press again. And again, I think. Yeah, so we had, it was 11 there, isn't it, a really horrendous rejection episodes that had microvascular damage and vascular lesions, but they also had an element, the varying elements of interstitial and tubulitis as well, but they were all C4D negative, and we could not find HLA antibodies, and we ended up giving prolonged plasma exchange, prolonged ATG, methylpred, and we managed to salvage all of these grafts, but it was a lot of work. And you can see on the far left that they all had varying levels of angiotensin receptor antibodies, and some had pretty high levels, and there were some there with DGF, where DGF was actually masking the fact that there were problems afoot. So you can see I've said delayed graft function day 3, but we biopsied within 72 hours, so I'm not sure it's sort of, so these were people who were not doing as expected. So if there were a live donor that we would have thought should be functioning within 12 hours or slowed right down, then they got biopsied. So delayed graft function doesn't quite fit the sort of standard criteria, but there's an interesting comment there.
How did you define about Q2 and not something else?
Yeah, that's true. So it's an inference. We can't show that they're bound to the kidney. That's exactly right. So we are making a judgment call there that unless we could show that there's ATI antibody binding on the graft, you haven't shown that for sure.
Sorry, could you repeat the question?
The question was, how do we know whether it was the ATR antibody is actually mediating the vascular damage? It could have been another antibody, and that's true. So this is an association. Does that help you?
Can I ask a follow-up? This is Anne helping. I'm curious, in this same group, did you rule out HLA DSA post-transplant in these patients also?
Yes, so the question is, did we rule out post-transplant DSA? And we absolutely did, because we were scratching our heads as to why they had such bad rejection. So we did all sorts. We diluted the serum, we dialyzed the serum, we did absolutely everything we could to try find an HLA DSA, and we were unable to. Is that okay as a response?
Yeah, thank
Good.
you. Sorry, Rob, sorry to interrupt, could I just ask you why you think children have higher, why do they more at risk for having these antibodies?
So the question is, why do we think children have higher levels of antibody? Well, I think they've got a better immune system. That's the first thing. And I think that the other issue is that probably they have more vascular lines. We don't know for sure, but I suspect that there's a lot more line usage in the pediatric population rather than having native vessel vascular access, but that's only me surmising that. But other groups have shown that relative to the adult population, the pediatric population has higher levels of these antibodies.
Do they have higher levels, or more of them have antibodies?
I'm not sure about the prevalence, but I think there are higher levels. In those that have them, they are higher. I'll have to look back at the paper. Sorry, Anne. Shall I move on?
Yeah.
Okay. So next slide, please. Sorry, next. Yeah. So the question here was, were we treating these people beforehand? And if you press the red, press again, there should be a red box, and again, and again, and again, maybe. Yeah. No, go back. Sorry. So 30%. Well, when we actually looked, 30% of our transplant recipients were coming to transplantation on an A2 blocker anyway. But what was happening after we found they had these angiotensin receptor antibodies, and we screened their retrospective sera, you can see that everybody got put on a candesartan. And you can see that the values there are pretty low, sort of 4 milligrams, but they're at least getting something. And most people will tolerate 16. We tried to get to 16, and very few people are on 32. But what happens then is, particularly in the hot Australian weather, that if they get dry or vasodilate in the heat, then you get changes in renal function. So we try to keep it 16 milligrams. So you can see already that all of a sudden we've gone from having, we actually had a policy of no post-transplant ACE or A2 blockade to, in these groups of people, everybody being on an A2 blocker. So we've really changed therapy or changed practice. Next slide. And really this is to show you that there aren't really many differences between those people who got no AMR and those people who did. And the things that really stand out are that the people who got AMR had higher, although this wasn't statistically significant, they were more likely to be a regraft, and that their ATII antibody levels as a median was 15. But there were, I'll show you on a subsequent graph, that this is the issue. Any detectable DSA, so that's sort of your sort of 600 or 300 cutoff, depending on your lab. So you could see that we're transplanting 20% of people with any DSA, and so what we would probably call a significant DSA was about 10%. And the de novo DSA rate, so we scan people at day 30 and at the time of any clinical event, and so it's not 100% surveillance, but these people were all surveilled for HLA DSA and de novo, and it's pretty low at 1 year. So it's about consistent with the literature. And I'm not sure what it is in Canada, but 50% of our grafts are 5 and 600 are mismatched. So we've got a really mismatched population. Yeah, so I think the reason I don't talk about that is actually the live donors. There were two recipients who had preeclampsia, and preeclampsia was the first clinical scenario in which angiotensin receptor antibodies were found. So the reason why that sort of skewed our data in a small data set is actually the recipients they'd had preeclampsia, and that's probably why they got the issue. Oh, sorry, next slide. And this is the spread of the angiotensin receptor antibody values. So firstly, you can have people who have very high levels, who have pushed in protocol biopsies at 12 months. They've got no problem. They're not on an ACE or an A2 blocker, and they've had no rejection, and they have a beautiful, clean-looking biopsy. But on average, there are people who have levels that have rejection. And we also have people in this area that get bad sort of cell-mediated rejection. And indeed, the data from big groups of 500 and 600 people is that ATR antibodies are just the risk stratifying for immune activation. And so they're at risk of any rejection, not just tumor rejection. Next slide. And what we did was we looked at the thresholds for risk for AMR, and 17.5 is the blue line and 25 is the red line. And one of the arguments to the rest of the group was, if we have a group of people who have a 50% chance of getting AMR and they're going to need 10 or 12 doses of ATG and 2 or 3 weeks of plasma exchange and lots of IVIG, okay, if we're going to overtreat 40%, but we're going to prevent this from happening, then we think it's acceptable that we can intervene in this group. So the first acceptance of the protocol was that we would plasma exchange to give ATG low dose and 3 milligrams per kilogram and candesartan perioperatively to people with an ATII antibody above 25. And so we affected a change in policy. Next slide. And so this is the Berlin protocol. Next slide. And that's the Adelaide protocol. So we sort of moved the threshold up because, to be honest, a lot of the receiving physicians and nephrologists were pretty uncomfortable with sort of intervening like this. And so we said, well, we will just see how we go. And we'll eventually, this means that we're intervening on about 15% of the population. We're not really affecting huge swathes of the population. Next slide. Yeah, tiny dose. Yeah, so 1 milligram sort of intra-op, 1 milligram post-op, and another milligram thereafter, and we interspersed it between the plasma exchange because that's the other issue. We've got to get it in and not pull it off when we plasma exchange. And so they get a plasma exchange 1 plasma volume before, and then 2 plasma exchanges day 1 and day 3, and we intersperse the ATG after that. But none of them get really anything more than 3 milligrams, so it's really a very prophylactic dose of ATG. So this was what happened to us in 2015. So our baseline rejection rate was about 25%, including subclinical, fell to about 8%. And we as a group thought, well, that's maybe just what happens in 1 year, so we'll see what happens into 2016, 2017. So next slide. Next slide. So that's just to remind you what was in 2013, 2014. Next slide. Back to 2015. So it's pretty much we've removed quite a lot of rejection episodes. So that's right. So next slide.
Sorry, we can't hear those comments from in the room there.
Okay.
Could you
so I'm going to explain it on the next slide. The question was what proportion got ATG between the 2 eras, and so it's on this slide is that we went from using about 6% ATG to 25%. So we escalated our ATG usage absolutely, but you can see that our rejection rate went from 27% to 8%, and the rejection rate in those people who had ATII antibodies above 17, which is the people that we treated or intervened on, went from 60% down to 7%. So yes, we escalated and we used ATG rather than IL-2 blocker, but we're only using a prophylactic dose. So just by focusing on those of high risk, we have modified the 2015 rejection rates, and there weren't really any other changes. So next slide. So we didn't get hyperkalemia. In fact, the only people that were dialyzed for hyperkalemia were the people who didn't get candesartan. And we did have slightly higher delayed graft function, so we had 30% of delayed graft function in the candesartan group, and we had 18% in the non-candesartan group when we excluded people who got rejection or a DCD kidney, but it's not statistically different. Next slide. This is a bit confusing, but there was CMV disease in people who were treated with ATG. But really what it boiled down to was, for whatever reason, there were more people who were donor positive to recipient negative in the ATI antibody group. And when you looked at people who were a D plus R minus, there was no difference between whether they got an IL-2 blocker or ATG and CMV or viremia, or the very few episodes of CMV disease.
But they were prophylactic.
They were prophylactic with Valgan, correct. And actually, there wasn't really any difference in sustained viremia with BK. In fact, it was probably slightly lower, and there was no, those people, there's only one episode of BK nephropathy, and that was in somebody given ATG for another reason, not for ATI antibodies. So next slide. a little bit confusing, but what I'm trying to say here is the ATR antibody prevalence of high-risk people hasn't really changed over time. It's pretty static. So it's about 16% of people have got levels that are over 17.5. But what we've ended up doing is we've ended up transplanting more and more people with a low-level DSA, such that we've gone from 19% to 20% to 36% of people with a DSA. And our rejection rates have actually dropped as well. So we've taken on more immunologically high-risk people and had less rejection. Next slide. And this is the 2016 data. So we've had a few more rejection episodes, but we've tracked it. I think we did, instead of 80, we did 95 people. So we still have low levels of rejection. We still haven't managed to get rid of the sort of severe cellular rejection. And we're still getting AMR with vascular lesions, but we're still at pretty low levels. So next slide. And this is no longer just tumour rejection. This is all rejection episodes, because predominantly now we're left with T-cell mediated rejection, and you can see that our 90-day rejection rate is essentially 8%. And our late rejection episodes are actually people, it's predominantly Indigenous Australians who've been non-compliant with medication when they go back, when they leave the central site. So all of those rejection episodes from day 62 onwards, whatever, are actually non-compliance episodes. So we've taken on higher immunological risk, and we've ended up with less rejection. Next slide. So rejection rates have fallen. We've changed the type of rejection we're seeing, and the question is do we just blanket policy of treating everybody? Do we adopt a Berlin protocol and reduce the thresholds for where we intervene? I suspect the answer will be no from the group. And do we need to alter the Adelaide protocol? Well, there's another slide, because I just want to show you what other people are doing. Next slide. So Annette Jackson from Johns Hopkins sort of told me what she was doing, or what they do with their team, and there is higher prevalence of ATR antibodies in people who are being retransplanted. So that's a given that's been shown in other groups. They test for ATR antibodies if they're thinking about HLA or ABO incompatible, and they test people who are broadly sensitized. So they're already doing preemptive protein exchange like us when they've had previous explained graft loss, very high ATR antibodies, and they've got other low-level DSA. So we're not just the only people who are doing this, but we're probably more of a blanket policy rather than being selective like Johns Hopkins. So next slide. So somewhere in the middle is the right policy, and we don't yet know, and I don't know. I do want to say that we've had horrendous rebounds and vascular rejection in ABO incompatible transplants when there's been really high ATRs. So I think if you're thinking about doing blood group incompatible transplantation, we used to do a lot of plasma exchange, which was great because we sucked up all of the HLA antibodies and all the DSAs, but now we've moved to using the columns that are selective for the blood group antigens. And if we've got people who've got very high ATR antibodies, we actually use a hybrid of columns versus plasma exchange to pull off all of the blood group antibodies and the ATR. I don't know whether at some point we can think about what Perlecan antibodies might be doing in this situation, and whether there's an interaction there. And obviously DSA, and we've become a bit more bespoke that if there's DSA and ATR, we'll plasma exchange and ATG them as well. Next slide. So it's really a lot of the slides from Duska in Berlin. Toby Coates is the director, and the team at the Red Cross Blood Service. So thanks for your attention, and I'm happy to take any questions. And if we do have time, I'm not sure if we do, I might be able to look at some clinical pictures, or clinical scenarios.
You can repeat what I'm saying.